prize from Avant. So I hope the winner is still here amongst us. So apparently they wanted somebody honest, so they picked me. Okay. Dr. C.E. Dr. C.E. still with us? Oh, up the back there? Gordana. Hang on. You're going to take it, Dr. C. Lovely. Thank you. Congratulations, Dr. C.E. Oops. You've got the mic on? Yep, ready to go. Yep, that's on. Yep, should work. No, it shouldn't do. No.
All right, welcome back, everybody. I hope you all had a nice break and you're ready to be able to give Gareth your attention. So most of you probably have met Dr. Gareth Kameron in the past, so he's obviously very active in the ADHD space in Perth, as well as still doing general paediatrics as well. So yeah, thank you so much for giving up your time and coming and educating us. Thank you.
Mic man. Yeah, he says it's working now. Is it working now? Yeah, no? Yeah, okay, sweet, excellent. So thank you everybody for getting me out of a couple of hours of being on call at the hospital. Saturdays are so much fun, stuck with, surrounded by snotty children and labouring women. And I can only throw my registrars and residents in front of that work so many times before I do get in trouble. Okay, so you might have noticed that I've changed the title of my talk just now. So what I'm going to do is talk about the evolving role of the art of ADHD medication management out in the community, because it is truly an art, but it's one of those things where you've got to know the science first and then you learn the art as we do with so many other parts of what we do in our daily life. I'm supposed to push the green button and it's supposed to, there we go. All right, okay, so quickly, who am I? So yes, I'm a paediatrician. At the hospital, I'm also one of the hospital's directors of clinical training. My portfolio is actually to look after the wayward registrars who have not quite behaving themselves, struggling with communication issues, those kind of things, which lends itself because the rates of, shall we say, ASD traits tends to be a little higher in our trainees who struggle with communicating with colleagues, especially nursing staff. Historically, I've worked down at Princess Margaret Hospital, where some of you may have run into me when you were in your junior years, and then I moved up to Joondalup, where I did both emergency work and then continue to work on the children's ward. These days, I don't actually do any paediatric emergency work, and I do a 50% split between the hospital inpatient general peds and 50% in my room. Within my room, half of that workload is ADHD, the other half is general paediatric medicine. So for those of you who've got constipated kids, I end up seeing a lot of them. I started a business called Peds Plus a couple of years ago. Some of you, I know a lot of you have referred to me, thank you. Keep doing so. We have managed wait lists, so yes, they end up on the list and we'll eventually get to them. And I have two sweet darling children, both have ADHD, and of course these days I would say that they're not so sweet, as they're 20 and 18. And one of them quite likes a beer at the pub, so I'm enjoying that engagement. The other one, not so much, but he'll get there eventually. Okay, so currently when it comes to what are you guys doing in the ADHD co-prescribing, historically somebody like myself or an adult psychiatrist would make the diagnosis, start the therapy, and then fill in some really annoying paperwork that required us to tell the government exactly what they were on, which specific GP and or GP group was going to be, had agreed to do the ongoing co-prescribing, submit it, etc. Thankfully that changed back in December, and now all I've got to do is basically start looking after them, and if there's a GP that I'm happy to co-prescribe with, I don't have to nominate. It's the concept behind it is that hopefully all of you are au fait with Script Check WA. So I assume everyone's heard of Script Check WA. I literally use it every day. It's part of my standard routine. I open it up at the start of my day and I have it running in the background because it tells me not only what I've done in the past, but also for patients who've come from elsewhere, it tells me who's prescribed what, when, what dispensing has occurred, etc. That's really important for me because I get families who say, I've run out of my medicine, can you write me an urgent script now, tonight? And then I can quickly look it up and discover that they not only have got 4 repeats left, but which pharmacy they went to get it. And my admin staff can then redirect the patient. But we still have to review the patients every year in paediatric population. In the adult population, it's 3 years between adult psych reviews at this point. So that got active in December. So it puts you in a position for patients over the age of, it's not clear, but 17, but definitely 18. They only need to see their psychiatrist every 3rd year. Now, I have no idea how well that's been taken up in the adult world, and I don't talk to them and they don't talk to me. Okay, so what's the proposed new GP prescribing rules? Everyone's heard all sorts of rumours and whispers and all this other stuff. I had a meeting with 2 senior GP college members only a couple of days ago, and the answer is it's unclear, no specifics or timing. The government will be making an announcement sometime in the next month or so. Watch this space. So what I want to do is roll on. Okay, so medication options, and I'm going to kind of blast through this. Some of you have given Belinda some questions. I asked Belinda to collect some questions that, as a collective group, that you'd like answers to. So I'm going to try to answer those sort of preemptive questions as we go along. And then at the end, I'm hoping to have some opportunity where you guys can ask lots of questions. But we're going to restrict that to 1 question per table and no follow-ups. Okay? So, 2 broad families. We've got stimulants and non-stimulants. Then we've got other drugs and we've got stuff to make them sleepy. So within the stimulants, you've got 2 families. There's the methylphenidate family and the dexamphetamine family. We're going to talk about them quite a lot. Then there's the non-stimulants, which is guanfacine, otherwise known as Intuniv, or atomoxetine, which is Strattera. Others, clonidine, SSRIs, which I'm assuming that you all have a relatively decent amount of experience with, especially in the adult arena, hopefully in kids to a certain extent. Some antipsychotics and risperidone. And somebody will talk about melatonin. So this is a bit boring, guys, sorry, but to understand how to actually look after the kids, you actually need to know the pharmacodynamics of what's going on. So how bioavailable are they? What's the onset? What's the half-life? How long do they last? What's the clearance of them? Because there are certain drugs that get affected by urine output and urine pH, for instance, and the metabolism. Metabolism's easy, it's liver. But it's part of the cytochrome P450 group, so you have to keep that in mind when you're playing with other medications that might have P450 activation or inactivation. Here's the kicker. With the stimulants, the actual exact mechanism is unclear. We know where it's working, but we don't know necessarily exactly all the steps of what's going on. And that's sometimes a bit of a barrier with educating families because they want to know exactly what the drugs do. We have to be clear and say we know most of what it does, but not exactly what it does. We know methylphenidate acts at the norepinephrine or noradrenaline, if you're Australian, dopamine reuptake inhibitor, and it therefore increases the amount of neurotransmitter in the gap, so therefore creating a stronger signal. I use the expression, it makes your brain more efficient. Okay? But one piece of advice I say is, remember, this is working at all nerve-to-nerve interactions, and not all of those interactions happen in your brain. They happen in your autonomic nervous system as well, and that leads to a lot of our side effects. So there's some really cool imagery online. This is a wonderful diagram of what's going on with all of the various ADHD medications, all on one graphic, and it's as confusing as all hell. So a better diagram is something like this. Basically, what it says is that by reducing how much of the dopamine gets reabsorbed, so we're blocking dopamine reabsorption as the predominant mechanism, it leaves more dopamine in the gap for longer, the receptors get it for longer, stronger electric signal, and off goes that, the potential continues on to the next part. But of course, we want it to target the bits of the brain that aren't very efficient, yet we have a medication that will just work at every single junction. So that's part of the reason why you get variable benefits, but also variable side effects, which adds to the complexity. So if you inhibit too much, then you end up with too much activation, and we can get side effects from that. I talk about the concept of a leaky junction. If we increase the amount of, oh, not that button, where's the back button? If we increase the amount of dopamine in there, but it's not reabsorbed fast enough, it might leak outside of the immediate junction, of which, of course, there's another junction nearby, and create havoc at that point. The way I explain it to families, why we get different side effects in different areas, is that some of these joints, most people when they draw it so it looks like a knee joint. So there's some form of convexity concavity interaction. Well, if you've got a convex concave junction that's shaped like two cups sitting on top of each other, then you've got to have a whole bunch of extra dopamine before it leaks out. If you've got two bowls, it's going to leak out faster than it would on the cup, but nowhere near as fast as if you've got two plates with the dopamine in between. So that's the way I explain it to the families. That seems to work with most of them. But there's, the next part for me, and this is actually the order of events that I do with my patients in front of me, is before I start talking about what doses and how we're going to escalate and change and stuff, I actually start by talking about the side effects, because ADHD medications has a really bad rap in the community. Sorry. I am actually on call for the hospital. I'm just going to ignore that one though, because it's a plumber. Although I know he's at the hospital because the hospital's leaking roof. So these are the top 10, and you see all of these on a regular, well, all bar one of them on a relatively frequent basis, and these are in order. Okay, so we're going to quickly go through all of them, and there's little tips and stuff as we go. So when you go and have a look at the Western Australian Department of Health handout for methylphenidate, it will tell you that the most common side effect is headaches, and in paediatrics that is not the case. The most common side effect is actually loss of appetite, and they say it occurs in roughly 1 in 10 children. I would contest that and say it's a sure thing. Every single child you put onto some form of stimulant will have an appetite suppression. About 1 in 10 of them, they will struggle with adapting to it so that they can grow sufficiently. So weight gain is a big issue. They all lose weight. A 12 to 14-year-old, I expect them to lose roughly 3 to 4 kilos in the first 6 months. Okay? Now, if I've got a rather generously proportioned person who's struggling with their weight, I'll lean into that and not give them any advice about how to adjust to it. And we might actually get a little bit of weight management as this nice little side effect. But you've got to be careful. So it's about 1 in 10, but it's the poor weight gain's the issue. Essentially, what you've got to do is you need to work on dietary strategies. The traditional Western approach of breakfast, morning tea, lunch, afternoon tea and dinner doesn't work. They're just not interested in eating during the day. So they might have some breakfast, but even our current breakfasts, which are very carb heavy, tend to not give enough energy throughout the day, and you end up with moody, hangry children in the middle of the day, and then the parents don't like the medication because it's interpreted as a side effect of the drug, whereas in fact it could be. It could also be a ramification of poor nutrition and insufficient sort of smooth calories delivered throughout the day. So never underestimate hungriness. And the other one, of course, is prepare for the ravenous beast. Those of you who have teenagers, either currently or in the past, know that at the end of the day, if some animal stops moving for a short enough period of time, they'll walk away with only 3 legs, especially with teenage boys. That is amplified. So you need to be ready for it, and you need to tell the family. The families need to accept that the kid's not just going to have a small afternoon tea. Afternoon tea, in actual fact, quite often really is their lunch. So we need to make lunch their afternoon tea. So there's a lot of strategies, and it takes a while. I talk about a fuel-air analogy, which is to do with cars. And I'll say, well, we've all drove here, we've driven vehicles, you put the fuel in, you put the air in through the radiator. If you want to make your car more efficient, you might put an additive. Well, the stimulants are the additive. But if you don't have enough of the fuel, or you don't have enough of the air, so that's you can think of one of them as food, the other one as sleep and hydration, then what happens is it doesn't matter how much additive you put in, it won't work as well. And you'll still run out of fuel by the end of the day and run out of energy. So insomnia, really common. It's the second most common one. A lot of these kids actually have predating, so before you start anything, they've already got insomnia. Those kids, I usually talk about the insomnia being a symptom of their ADHD, an inattentiveness to their own melatonin. Okay? Unfortunately, it is substantially and spectacularly made worse by poor sleep hygiene, which of course, as I've answered my phone, is predominantly these days based around screen addiction, with at least 50%, if not 80% of high school students having screen addiction to some extent. So yes, you can throw melatonin at them, but if you're not addressing the sleep strategies and the sleep hygiene, you're not going to have anywhere near as much success. And screen time's just bad, just generally across the board. I don't think anybody in the room would necessarily agree with that. Disagree with that, I should say. Nervousness is the next most common. It's better described as amplified emotions. It's amplified in two ways. One is how quickly the medication blood concentration comes down, but also hangriness. Some kids, the younger kids in particular, at lunchtime they will literally just cry. And when you ask them what's wrong, they'll say, I don't know. And they genuinely don't know. They're just crying for no apparent reason because of the consequence of the blood concentration dropping rapidly. I'll show you a slide in a minute of what it means. It happens around lunch, and then at the end of the day, it's worse with the hangriness, and it settles with time generally. Most kids, if you can't move them off the short-acting onto something long, will adapt to it, but it can take weeks to months, and some never do. That's important because 5-year-olds, we can only use the short-acting medication based on PBS regulations. Headaches, not particularly common. If you do see it, usually it's all about hydration or poor sleep or both. Typically responds to paracetamol and Nurofen and settles down within a few weeks. In the adult world, it's quite common for a person in their 20s or 30s just to be thrown straight onto Vyvanse, and the psychiatrist hopefully tells them there's a reasonable chance you'll get headaches. Persevere, take Panadol, Nurofen, they should settle within a few weeks. In kids, we try to avoid that because if I give a drug to a child and they get headaches, they then just won't take the drug. So we start with very low doses and build up slowly. And obviously be mindful of a family history of migraine. So you need to, if that's there, manage that optimally and be ready for additional headaches if you start. Nausea and vomiting, this varies a lot depending on which formulation of which medication you might be using. So it's not particularly predictable. However, it seems to be substantially more likely in kids who have either a history of constipation, to the extent that I now, if any child rocks up with these symptoms having started on, it's one of my screening questions before I start anybody is I actually take a bowel management history right back to the newborn period to see how they're going. And if they do have the symptoms, I'll actually treat them for constipation, even if the parents say, no, there's not a problem at all. And most of the time that sorts it out. Okay? And you found another problem you didn't know was there, and you've made that better at the same time. Okay? Tachycardia is very infrequent. There's two main issues with it. One is it can be, you've identified, it's usually tall, skinny girls who are underhydrated. And those kids, once again, you manage the hydration, the exercise, and it tends to settle. But every once in a while, you'll come across a child who you actually identify that they've got a pre-excitation scenario. I'm currently looking after a girl who a paediatrician in Brisbane, started them on stimulants, got severely tachycardic. ECG showed a Wolff-Parkinson-White picture, and we can't use any stimulants. Now she's got ablated just recently, so I'm going to be very tentatively starting her back on stimulants shortly and keeping my fingers crossed, okay? Because we don't know what's going to happen. Normal investigations, if you've got unexplained tachycardia, jumping from one stimulant to the other, you may see no issues with the second stimulant. You just don't know until you try it. It's a lot of trialling and erroring with your patients. Dizziness, same deal. It's the same kids that tend to get the tachycardia. Usually indicates the standard reasons why teenagers are having the dizziness. So it's focusing mostly on that. Okay, and they don't like it when you say get off your phone, do more exercise, and eat better. And we've all had that conversation with a teenager. Okay, you walk away frustrated with a sign that says beat head here. But if they do it, they get better. Nasopharyngitis, even less common. It's transient when it occurs. The way to think of it is they've got a head cold without the fever. Of all the kids I've seen, I've ever seen it once. Okay. Growth restrictions, once again, very uncommon. Statistically, it's been proven. It's one of those, it's statistically significant, but it's not necessarily clinically significant. In that, yes, the cohort, the big bunch, they'll end up being maybe 1 or 2 centimetres shorter, but it's an easy sales pitch. Would you rather have a more functional, slightly shorter 18-year-old in society or a slightly taller, less functional child at 18? So the only kids it's really an issue with is those who are already sitting on the first, second or third centile. And for those ones, and I have about half a dozen of these kids, I actually have them both on growth hormone and stimulants at the same time because they met both criteria. But that's a rather complex scenario. And then aggression. This is the least common. It borders on rare. Most paediatricians will do a 20-year career without seeing it, and it is uncontrolled rage. There's not a lot in the literature, but there seems to be a predilection towards teenage boys and probably, I'd say, testosterone and accidental overdose association. I've seen this with my emergency hat on. I've seen it several times from other paediatricians' patients. From my own caseload, I've seen it once, and I was filling in forms for the insurance company explaining that this is a side effect and it's uncontrolled range because he literally destroyed the front of their house. And as soon as he came down off that, he was extremely remorseful, but the police were involved, he was handcuffed. It's quite dramatic if and when it occurs, and you can't predict. And it's an immediate stop. You can tentatively trial the other stimulant, but generally speaking, they end up being switched to a non-stimulant. All right, so what's the aim of what we're doing? So the typical daily needs, you've got to ask yourself the question, the purpose of the medication. And when I ask families this and people, the most common answer is to help kids in school. Has everyone heard that one before? Help them at school? Okay, for everyone who said yes, you're all wrong. It's a solid, that's not a big enough picture. The goal or the role of this is not to help children at school. It's actually to increase the child's likelihood of having a successful day. Now, on a school day, that's measured in academics, but it's also measured in how well they make friendships, maintain friendships, how well they go with conflict resolution, building confidence, resilience. And on a weekend, it can have massive impacts on whether they get invited to birthday parties. Because if they go to one birthday party and they've got impulsive ADHD and they terrorise the place, don't listen to the instructions at the party, and it becomes nobody likes, Phil being there, then that child doesn't get invited back to the party. So my advice is 7 days a week until they finish formal education so that they have a significant likelihood of having a successful day consistently. So that is the philosophy. And every parent goes, that's a great philosophy, I like that. Okay? So that's the purpose. As the day goes on, they actually usually need more help because our brains get tired. So this is the first graph, there's some more coming. So this graph shows the blood concentration, methylphenidate 10 milligram immediate release tablet. As you can see at time 0, 0, it goes up, it peaks at about 2 hours, and then it steadily drops off. But the child's actual daily requirements is roughly represented by a line that steadily goes up as the day goes on. Where is that line? I haven't got a clue. What's the concentration they need? It changes every single child. How steep should that slope be? Who knows? Okay? And these are all the unknowns. They're the things we can't measure. But that's the principle. But of course, we need it to last for the duration of school, at the very least. So a short-acting tablet by itself, if they need to be above that line on my graph, is not going to cut it. They'll get to about lunch and then they're toast. And we actually get around about 4 hours worth of benefit on an immediate release. So these lines I've done in specific reasons. But then, of course, that's going to affect their appetite for that. For this child's going to get 4 hours of appetite suppression and then they'll be hungry afterwards. So we're not going to have any weight issues. But then I need them to get to sleep. So they need, that doesn't project, that's right. They need to be sleeping somewhere roughly, this is a primary school child. So if they take their medication at 8 in the morning, I want them sound asleep by 7 or 8 o'clock at night, which is roughly 12 to 13 hours later. So I need to make sure that the dose is high enough to get the benefit, but then low enough so that they can go to sleep, keeping in mind that they may already have some issues with how they're responsive to their own melatonin. So, and we're measuring all of this in how they're functioning. So we've got lots of formulations. Have I lost anybody yet? I told you it was a bit dry, sorry. Okay, so that's short-acting Ritalin, as you've seen. It's got 2 hours before it starts working it's 2 hours to peak concentration, but you usually see a benefit within about 30 minutes. And it lasts around about 4 hours with a 2-hour half-life. So Ritalin graphically is relatively easy. It makes sense. The drug goes up, it comes down, and there's like a threshold. It goes up and over it, and we see it's working when above that, but it's not when it's below that. Kind of makes sense. The long-acting is the red line. The blue line is if I give 10 milligrams of Ritalin short-acting at 8, and then another 10 milligrams at 12. So that's 20 milligrams in the day. But if we do that, what we end up with is in this slumpy bit. I don't use the laser, guys. I'm actually colourblind, so I can't see the damn thing. But this bit here is where we get the emotions here, because they've gone from functional, they've rapidly crossed over that threshold. Remember, it was sloping that way. And they go from being, yeah, everything's working okay, to, oh my God, my brain doesn't work anymore. It makes the kids very emotional. So the long-acting benefit is we're not doing that. It's far less of an exciting roller coaster. And it works quite nicely for most kids, about 95% of them, but 5% of them, annoyingly, and AJ, our gastroenterologist, might be able to answer this question because nobody else has been able to. AJ, you're on the spot, mate. No, I'm kidding, it's all right. So the way the long-acting is done is it's actually a 2-part capsule. Inside the capsule, it's got small and large granules. The large granules are just the small ones with an enteric coating on them. Interestingly, the enteric coating is actually made of a similar material to any 3D printer that's got the filament in it. So it's a cornstarch-based coating. And in theory, it takes 4 hours for it to break down, hence a little bit beforehand. Most of it comes out 4 hours later. Some kids, about 5% of them, and I cannot pick which ones, they break down that enteric coating really quickly. And so instead of having that red peak all the way at 4 hours, it peaks at about 2, and then it comes down extra hard, and you get about 6 hours worth of benefit instead of the 8, 5 to 6 hours, and they're an emotional wreck on the way down. A lot of those kids, you go, oh my God, there's something wrong with methylphenidate, but it's not actually the methylphenidate the issue, it's the formulation and how it's being delivered. And you can't pick which kid's going to do that. It's annoying. I just have to warn them and keep my fingers crossed that they're in the 95% where it works okay. But this one, you can see it, for a primary school kid, it's worn off really well by that 12-hour mark. So most primary school kids do fairly well on the long-acting unless they break down the second wave too fast. If somebody asks me why is it, I say, nobody knows. It's probably a gut microbiome thing. Nobody knows. People have looked at whether it's acidity or this or that, and nobody seems to work it out. So we just blame the little bugs inside us. Then the next formulation, everyone's heard of Concerta. Concerta is a super fancy medication. It's just methylphenidate, except it's inside a plastic capsule that doesn't dissolve, so it comes out in your poo, which is not a problem unless you live on a farm. Then I need to find out what kind of septic system they have. Because if they've got an accessible septic system, it's okay. But if they don't, if they've got a leach septic system, you can't put them on Concerta because it will block their system, and then they really won't like you because the plumbing costs are very expensive. Isn't Paediatric's wonderful? All right. So the benefit of this is it's an even less exciting roller coaster ride of drug concentration. All these graphs, by the way, are actually from the manufacturers. These are actual blood concentration curves generated in the early phases of the development of these drugs. So if you're really, really bored and you really have a lot of time on your hands, you can go and pull these off the FDA websites and all that kind of stuff. Clearly, I was very bored. But as you can see, it crosses that 12-hour threshold and it's still at a reasonable dose. So generally speaking, the primary school kids is not ideal. But in a high school child who needs to get homework done and wants to stay up late, or should be staying a bit later, that we can push that blue curve, that blue box to the right, and the levels are low enough. Okay? Then we play with dexamphetamine. Dexamphetamine's annoying. Okay? Because if I drew that funny little horizontal line here, same as I had on that first slide, you'll see that at 4-hour mark, the dose is still really high. In fact, this actually only peaks at 3.5 hours, but it only lasts for 4 hours. This is the element of we don't know exactly how the drug's working, because you'd think that if the drug's high enough to make it work, but then it's still peaking at 3.5 hours, but half an hour later it stopped working, why has it stopped working? The answer is nobody actually knows at this stage. Then the another annoying part is the half-life changes dramatically depending on age, but unpredictably. The younger a child is, the more likely you are to be closer to the 4 to 6 hour mark. The older a person is, and I'm talking through to adults, not geriatrics, 9 or even 12 hours. And you can't predict which one it's going to be. So you can get quite a lot of variable, not so much benefit, but side effect. So the side effects seem to track the blood concentration far more so than the actual benefit does. And those two curves, the one on the left is if you've got a 6-hour half-life, and the one on the right is if you've got a 9-hour half-life. And they don't look like a lot, but you can't predict it. The other annoying thing with dexamphetamine is it leaks into your urine, anywhere from 30 to 50% depending on the pH. So the higher your pH, the more it leaks. So you can get variability depending on your diet on the day. So it's a bit annoying. Then we've got Vyvanse. Vyvanse is dexamphetamine with a molecule added to it. I have a bit of fun, and is any Elizabeths or Liz's in the room? Seriously? No? Great, excellent. So everybody knows that Liz's are useless. So what we do is we get the dexamphetamine and we attach a Liz to it. Now the Liz is actually lysine, the amino acid. And you swallow it, it gets absorbed quite rapidly, high bioavailability. It's got a 1-hour half-life to get rid of the Liz, which happens in your bloodstream, releasing the dexamphetamine in a smoother curve. But as you can see, it's still very morning heavy. And we know from the slope that your requirements actually go up as the day goes on, not down. So your Vyvanse actually has the shortest duration as a long-acting agent, contrary to marketing. It was marketed as a 12-hour plus agent. Independent post-marketing and post-research studies have shown that 6 to 7 hours is a more realistic time frame for Vyvanse. And for those of you who have any adults who are on it or anybody else on it, you'll quite often find they say, I take it at 7, it takes an hour and a half to work, and it's done by the time I get to 3 or 3:30. And that's a realistic time frame of the benefit of it. So if you need to get them to last longer, you've got to give them Dexies later in the day, which in primary school is a real mess because they're inattentive and they forget to go and have their Dexie top-up at lunch. And in high school, you haven't got a chance because the schools don't police the taking of lunchtime medication except in very certain circumstances, and ADHD is not one of them. Which stimulant's the best? Should I do a show of hands? Who thinks which one's better than the other? What do you reckon, Lena? Oh, okay, so which one's the best? Who thinks Ritalin's the best? Anybody? Brave enough to put your hand up? No? Oh, that's no fun at all. All right, so there's an argument, and research will tell you this, that, or the other. The short answer is the best one is the one that works best for your patient. And you don't know until you trial them. Generally speaking, I talk about these numbers. I'll tell families, and these are not scientific. This is not research-based. This is just observational. And it gives the families a nice framework of expectation. About 80% of kids, if I put them onto Ritalin, I would expect them to have an overall positive response with manageable or minimal side effects. The next 15%, I'd say, you're seeing some definite positives, but the side effect profile is starting to get a little bit too complex or it's just not working. The next 4%, no positives at all, lots of side effects. And the last 1% literally doesn't seem to do anything. Nothing, no positives, no negatives. I actually had a child in my office just yesterday who was the classic, Ritalin did nothing for this child, and I mean nothing. Trialled by a previous paediatrician mum couldn't quite remember what way in another country, came to see me, I trialled it again, nothing. But we put the child onto Vyvanse, significant and dramatic improvement pretty much on the first day. And so then it just became a matter of, I'm now in the fine-tuning process trying to find the right balance of what's the right Vyvanse dose, do I need to add Dexies so we achieve a nice positive outcome. So which ones do you start on? Well, me personally, I start pretty much every single kid on Ritalin short-acting, regardless of age, regardless of diagnosis, regardless of severity of symptoms. I just put them all on Ritalin short-acting. Now, why do I do that? And the answer is because I find it to be the most finessable to try to get the balance of benefit versus duration and how to minimise the side effects as the day goes on. When do I switch only over to dexamphetamine Vyvanse family? The answer is only if I can't make the methylphenidate family work well. Because methylphenidate, most of the finessing is done at home in the morning. So you finesse their meds. You'll see a slide in a minute of how I do that. The dex is you finessing at the end of the day. And that's much harder to achieve with the younger kids in particular, a little bit easier if you've got a more mature, more cooperative, not inattentive ADHD child who has insight. There's a lot of ifs there, so it makes it difficult. Generally speaking, in the younger the kids, the more likely you are to have success with the methylphenidate family. By the time you get to late adolescence, it is literally 50-50, and there are plenty of research articles that back that. Why do adult psychiatrists use Vyvanse all the time? The answer is because if you're diagnosed as an adult, Vyvanse is PBS subsidised, $32 a script for a month. But if you then want to put them on Concerta 54, they're paying $60 a month for their medication. Because if you're diagnosed as adult, PBS does not subsidise the long-acting or the Concerta of your methylphenidate. So there's a skewed practice going on because of that phenomenon. Paediatrics, once you're diagnosed as a child, you've got access to all of them under PBS for the rest of your life. Makes it easier. So we can play some mix and match. We've only talked about single agents now. I have a large percentage of my patients who are on more than one agent or more than one formulation specifically of an agent. The most common one I'm going to show you graphics is if I pull up the Concerta curve, and this is a very stylised graph, it picks up in the morning, picks up around about 11 o'clock, assuming they take it at 7, and then it wears off. But the next strength up is quite a big step up. And the morning dose might be beneficial, but the afternoon dose becomes too much for them. And there's nothing worse than overshooting, having to pick up the pieces of losing faith in the family, or they lose faith in you, and the kid might not want to come in and see you again. So I use an in-between where I will prescribe, this is the 27 milligram curve, the bottom one, 36 for the next one. I'll give them a 27 milligram for breakfast and a 5 milligram short-acting. Same time, you get the blue line. And that combination works really nicely. And that might get you an extra 6 months to a year before you have to put them up to the next highest dose. So these are some of the patterns that you're going to be seeing with paediatricians. Okay. Non-stimulants, guanfacine, some families online, of course, we're battling constantly with Dr. Google. Or now it's, what's the Google AI called? Not Chat, or ChatGPT, yes, but these various AIs are now, whenever you do a Google search, the first thing that comes up is always, whatever Google's AI is called, its trawl of information, it puts it up there. And sometimes it is sold with a strong language that makes it look like it's absolute fact when in fact it's not. So families come in with expectations. I had a child come in yesterday and mum was there going, can we just start on guanfacine, and I'd like my child diagnosed with ASD as well, and I think they've got rejection sensitivity, whatever it is, which is not a thing, by the way. So there's a lot of family-directed expectations and diagnoses, and you have to spend quite a lot of time going, no, let's just stick with what we know and address those things. So guanfacine's way less bang for your buck. At best, you'll get about a 30% equivalent benefit to a stimulant, but sometimes you just can't use the stimulant. It is first line with our eating disorder patients. So generally speaking, if you've got a kid who's got an eating disorder, they should be managed down at PCH or an equivalent service with the appropriate skill set. But if they really need to have their ADHD managed, guanfacine is our go-to because it does not make them hungry, nor does it make them lose weight. So the patients are happy and the doctors are happy. Okay. You guys, one of the questions was asked, can you guys start Intuniv? The answer is no. However, once it has been started, then you can continue it and it doesn't require a yearly review by the paediatrician. So we have to start it, but you guys can continue it, and I don't think that's being addressed with the current changes that are coming through. It is less predictable. We started at night because the most common side effect, hands down, is it makes them sleepy. More than half the kids within an hour of taking it will be sound asleep. So you give it to them at breakfast time and they'll be asleep in the first 3 hours of school. So not ideal. It's a transient side effect. We give it to them at the end of the day, at night time, helps them sleep, and then over time we shove it to the morning. Atomoxetine, in all honesty, I don't use it because so far I've never had to. I've always found another solution that works quite well. And it has very little usage in the community. It doesn't get a lot of usage in Australia. You can mix and match. You can have Concerta and Vyvanse and/or, not both at the same time, but you can have Concerta with Intuniv. You can have Vyvanse with Intuniv. They're quite often used to manage mood regulation. That can be quite helpful, especially in adolescence. And it allows you quite often to get away with a lower dose of Concerta. You want to turn the Concerta up, but they get side effects, so you keep it where it is. You put some Intuniv on top. You tend to amplify your benefits without increasing your side effects, and it tends to help with mood regulation. So that's another balance. When do you do this? The answer is you've got to know the kid really well. There's no hard and fast rule. And it's a trial. This is the layout of the Department of Health handouts with regards to all of these. These are all available online, and I just have them on my computer and I print out whichever medication I might be using. I'll give them the handout. They're all two-sided, single page, double-sided. They're all very easy to read, and it lists the side effects. Other things we use, I'm just mindful of the time, guys, so I'm just speeding up at this bit. So clonidine, SSRIs, aripiprazole and risperidone. Clonidine's very old school. We can use it in the under 5-year-olds where I can't use a stimulant. It is a cardiac drug. It does have sedating qualities, but it basically just calms them down. It's not ideal to be used during the day, but it can be quite helpful in those kids where melatonin is not enough for sleep. So you max the melatonin, and then we'll add the smallest amount of clonidine we can get away with. So that can be quite helpful. Also use it a fair bit with our level 3 autistic children. The stimulants might be working for the focus concentration, but the agitation's too much, and so we'll use a clonidine during the day to work with that. You guys can start that, okay? But you've got to be careful with it because it will drop their blood pressure if you give too much. So it's gentle in and very gentle out. SSRIs, everybody in this room has prescribed SSRIs multiple times in your career, I'm sure. These are the top 4 in order of how likely we are to use them. Why sertraline before fluoxetine? The piece of advice I got from a paediatric psychiatrist is, it's a tablet, you can chop it in half or quarters. So it allows you to give a smaller dose easily, whereas the fluoxetine only comes in a capsule or in a dissolvable tablet, which is not particularly palatable, but also the supply of that dispersible tablet is hit and miss. Sometimes we've got heaps of it, and for reasons that I've never been able to work out, we just don't have it for a while. So it makes it challenging in that circumstance. Escitalopram and citalopram you can also use, but not as commonly as the first two. Unlike all SSRIs, slow in, give it time to work. You can optimise, and then if you have to come off it, you've got to come off slowly. There are transition strategies that you can find online, so I won't go into that. Aripiprazole is another one that some paediatricians will use in conjunction with advice from a psychiatrist. It's an atypical antipsychotic agent that can be quite good for ADHD symptoms and a lot of emotional regulation issues, especially if you've got depression as well. So we use it mostly in our adolescent population or in our extremely complex autistic children who have autism, anxiety, depression and ADHD, where we're having to try to find the minimum number of agents that are going to help us with our symptom profile. It's only PBS approved for schizophrenia, so it's all off license and it's all private scripts. Risperidone, been around for a lot longer, has a similar effect as the aripiprazole does, except it makes them all really hungry. So they all put on a lot of weight. So you've got to be very careful with that. It's quite good for complex behavioural issues, especially if they're an aggressive child. And it's only PBS approved if you have been formally diagnosed with autism. Otherwise, it's a private script. Future stuff. Well, firstly, the Concerta patent has expired. So in the US, the FDA has approved a competitor that uses the same capsule technology as Concerta. It's only just been approved but PBS, TGA so far have not announced whether they're going to look into it. If that company's smart with our current shortage, they will get approval, and so that they'll then get a good corner of the market in Australia and the rest of the world. You can get transdermal methylphenidate as well. It's not available in Australia. It's not used particularly much, but it's evolving. And then there's a new medication coming that's in early trials. So it's probably 5 to 10 years away. It equally works by, it's another reuptake inhibitor. But technically, for whatever reason I don't understand, it's not classified as a stimulant, even though it works at the same receptors. Go figure. All right. So co-prescribing tips, guys. You've got to get onto Script Check WA so that you know what we're actually doing, because you can't trust the families. They've got a child with ADHD. You've got at least one parent with ADHD. So they'll forget what they're on, when they were on it, when they changed, when they last picked up a script. This will tell you at least that aspect of things. Please remember to count the days. The stimulants you get, 30 in a container with 5 repeats, but you're in tune if you only get 28. And we quite commonly would say, I'll see a child, not in 6 months, but I'll see them in 5.5 months for their stimulants, but I need to see them in 5 months for their Intuitive. If you see them in 4.5 months for the Intuitive, that's great for the Intuitive, but then I can't write a script for the Concerta because it's too soon. So you've got to be careful with the timing if they're on both agents in particular. And sometimes it's really important to let them accidentally miss a day, because families will go, we're not quite sure if this is working anymore. Doesn't seem to be doing much. And I say, have you skipped a day lately? No, just skip a day. And then what happens is they'll come back and say, oh yeah, it's definitely doing something. So then it comes down to, okay, so yes, it's doing something, but we clearly don't have the right dose. And then we start that conversation. It takes them from being, I don't think this is working, to I know it is, we just haven't got it right. FYI, there is a push online happening in certain areas to say that once you've been on the drug for X number of years, it becomes ineffective. So that is out there on the internet. Otherwise, it comes out and says, oh, it doesn't work as well, et cetera, et cetera. So you'll quite often find late adolescents, when they're showing independence from their parents, they might go, oh no, it doesn't work anymore. I found this website article, et cetera, that says that it doesn't work. And it's not factual, but that doesn't stop people believing it. The next one when it comes to co-prescribing is, if I've got 100 kids, I've got them on a lovely stable dose. In 6 months' time, 75% of them are probably going to need a dose adjustment. And the other 25 will definitely need it within, or probably most of them will need it by the 12-month mark. With the kids, the little buggers are constantly growing. They're maturing, they're changing. So many things are going on. And you do need to constantly be thinking, have I optimised? I need to keep changing, updating. So it's quite a lot of work to keep them on top of where they need to be. And you don't know, just because they put on 2 kilos doesn't mean that they need to go up by 5 milligrams. They might put on half a kilo but need to go up by 10 milligrams, or they might put on 5 kilos and not need to go up at all. There's no rhyme or reason behind it. It's literally case by case, kid by kid. Puberty is a pain in the ass. Okay, you might have a child who is beautiful and stable, and then 2 months later you're doubling their dose, unpredictably. You just don't know. That's why we need to be adjusting regularly. And the other one is girls, our menstruating population. Some girls, but not all, will need an increased dose for a week, and then they need to go back down to their lower dose. And it's quite difficult to manage that, because you can only have one long-acting stimulant prescribed at a time. And what do you do for those girls? And each one needs to be managed independently and individually. All right, so you guys asked some question. Can you prescribe Intuitive? The answer is yes, only once somebody else starts it. Why do kids start on short-acting formulations? The answer is, if they're under 6, I can't put them onto a long-acting unless we go off PBS. So I do have some 6-year-olds on, some 5-year-olds on Concerta. It's extreme circumstances, and with a full understanding from the family that they are going to have to pay the full price, okay? Which is roughly double what it's going to be. And then there are clinicians who have a habit of just leaving the kids on short-acting for a long time. If they're in the public system, they're more likely to be on a short-acting for longer, and that's mostly due to the fact that they'll go back in and see that registrar on the first appointment, this registrar on the next appointment, that registrar on the third one, and it's hard to get a feel for how that child's evolving when you've only met them for 30 minutes. So some kids will stagnate in that scenario. Long-term melatonin, it is safe. Who's been on a plane lately? Because if the answer is yes, you're putting your hands, if your faith in somebody who is taking melatonin on a regular basis. So it is safe to use, but once again, online there is stuff out there saying that if you take melatonin for too long, it'll have issues with erectile dysfunction, it will have issues with fertility, it'll have issues with all sorts of stuff. And the short version though is it's basically safe. I find that if the child's on it consistently, they actually learn the strategies to get themselves to sleep better, their hygiene improves, and then they don't need it. So it tends to work in your favour. Maximum dose of melatonin. Teenagers, it's 10. I send everybody to the iHerb website, by the way. I say, iHerb website, 5 milligram gummies. Why? Because if it's too much, you can chop it in half easily. And if it's not enough, you can give them 1.5 or 2. So I normally start my patients on 5, unless they're quite young, in which case it might be 1 or a 3. The idea is to find the lowest dose that gets them asleep within 30 minutes, okay, from saying goodnight. But yeah, 10's the absolute max. But primary school kids, you're probably going to top out at 5 or 6. Weight monitoring, prepubertal, aim for 1 kilo every 6 months. This is just standard normal weight gain. Hearty breakfast, I recommend things like bacon and eggs, sausage sizzles, puff pastry, egg cups for those of you who are a little bit more sophisticated. Muesli bars during the day. You've got to teach them to eat socially. Are your friends having food? Yes, then you have to eat 1 muesli bar. In high school, you can make it a nut bar. In primary school, obviously, you can't. So you've got to be mindful of what they're having. That way, the families don't burn their money when the kid comes back with a full, beautifully made sandwiches that are just going to go off. So I send them to school with 3 muesli bars, 1 at the start of recess, 1 at the start of lunch, 1 at the end of lunch. Teachers will quite often help with that as well. And it's quick, easy, done. The little buggers can go and play. Car snacks, I tell most of my families, make sure when you pick them up from school that when they sit down, they have to take some food before they sit down. Shovel the food into your mouth before you let them out of the car at the other end. If you have to do a slightly longer drive, either you shouldn't be driving them home, or find a longer route, take them to the shops on the way home, something else. That gets rid of the hangriness. And you aim for a good weight gain 1 year after stable long-acting. So I let them lose weight, and a year after I put them onto, I'm happy they're on a long-acting. A year later, I'd like to see that 2 kilos. So you've got to have patience. Sleep, no screen time in the 1 hour before lights out. TV viewing in a well-lit room. If your mother can't read her Mills and Boon novel sitting next to you with the ambient light, it's too dark. Okay? Take your melatonin an hour before lights out. That's what I recommend already. Reading is really important for the kids. It helps them get all sleepy. And graphic novels don't count as reading. It's really important. And neither does reading the good old, Guinness World Record books. That doesn't help them either. It's got to be a fictional novel at bedtime. Magnesium can help, nice and safe. There are no recommendations to what the dose is. So generally speaking, if they're in high school, give them the adult dose. If they're in primary school, give them the half adult dose. If they're a tiny, scrawny little kid, a quarter. Clonidine and Intuitive can both be helpful. I know I'm running out of time here. And what did I do to get to this point? It's not been quick, guys. As I said, there's a lot of art in doing this. So I did 6 years as a paediatric trainee to learn kids. Then I worked in ED. I've got a couple of kids myself with it. I did 6 years of private rooms before I felt confident actually having a crack at it after Professor Silver nagged the hell out of me for a couple of years to do it. And then she and another paediatrician gave me one-on-one training for over a month where I ran every single case I had past them. So it's not a quick, easy thing. I felt that between 1 and 200 I was starting to get okay at it, and I now manage about 600 kids. Okay? Right. There's one person with a hand up, so you get to go first. Hold on, there's a microphone coming. Got to get in early, guys. You miss out.
Have you got any useful resources to help us when families come in and say, oh, we're going on holiday, we've got to take the medication with us?
Right, so the good old travel. Generally speaking, the patients I look after, I'll actually generate travel letters. The advice I give is you need 2 letters. You've got to think, is their current script going to last long enough? So you might need to write a letter to the pharmacy saying, can you please do an early release of the next script, which you can do. And then depending on where they're travelling, I recommend a letter to the customs officer, basically saying, dear customs officer, this kid's got ADHD. they're on this medication and this medication, these doses at this time, and that will get them through everywhere. The only two countries you've got to worry about are Japan. Japan, they have very, very strict laws about stimulants, and so they need to go to the Japanese embassy, download some stupid form, fill it in, and you've got to send the accompanying letter. Singapore's the same, but theirs is a little bit less clunky because it's online. There we go.
Besides the medication for ADHD, and you mentioned sleeping hygiene, there is any other things we can suggest the parents to help the child, like nutrition, some, any other things besides pharmacological?
To help them with sleep? The main thing is good sleep hygiene, so it's timing, wind down, reading books, and not hyping them up, those kind of things. But there are lots of non-pharmaceutical things you can try, herbal remedies, etc., etc. Most of those will be completely safe, so it'll do no harm. Probably the most common non-pharmaceutical benefit you're going to get is from magnesium.
Thanks for your talk. I just have something I just like your opinion on. So I have a young 8-year-old with ADHD and severe aggression. They've tried him on pretty much all the stimulants. It didn't work.
Yep.
And in the end, the registrar wrote a letter back to me and said, we can't help him anymore. Can you please, as the GP, start fluoxetine 5 grams for him? So...
Jakey?
Yeah. And I was like, this is where I get confused. I'm like, if you're a psychiatry registrar, why can't you, if you feel so confident about this SSRI in an 8-year-old, start it? Why do I have to start it when I feel this is not the correct way to go?
This is a political answer.
Thank you.
The political answer is, within CAMS in particular, there is a mandate written into their work practices that they do not manage ADHD, nor do they manage ASD. And if they think a child has severe depression, anxiety, then they will actively manage it. But if they don't think that that child is at risk for self-harm / suicidal, then they'll go, well, that's not high enough risk. So they're giving advice, but they just told you're not allowed to manage these kids long term. It's a business strategy within their organisation. I don't agree with it, I don't like it, but I've shouted into the wind many times in the past and gotten nowhere. And so have most of my colleagues. I think this gentleman had one.
Something I heard somewhere that antidepressants should not be used in ADHD patients. Some patients come across their hearts, and we're talking 18-year-olds. Now, that's something I would like you to say, yes, it's true, or no, there's no such a thing, especially with the SSRIs here. The second question is really, how does SSRI work in ADHD here, and do they need to be combined with the other groups you just talked about?
So the SSRI is not addressing ADHD. SSRI is addressing the comorbid anxiety and or depression they might have as a consequence of being unsuccessful in life. Now, that's why I like to manage, that's why the philosophy is help them be successful with the stimulants. That reduces the rate of anxiety, depression. But some kids, there's a strong family history. Is it safe to use stimulants and SSRIs together? The answer is absolutely. Do you need to do much consideration between the two? The answer is no, not really. I run them in parallel. I'll optimise my stimulant medication plus or minus my Intuniv if I'm using that, and then the SSRI run independent and treat it as if that's the only agent you're using. So it is safe to use, but you need to be using it to address the anxiety, depression that they might have rather than trying to fix their ADHD.
Hi, thanks for the talk. How do you switch from one stimulant to the other? Is there a washout period required?
So the short answer is the next day. So if I see a child in my office who's they're not enjoying their, Concerta, and they're having side effects and I want to put them onto Vyvanse, I'll literally write a script and say, start that tomorrow. They wash out quite quickly. Come the next morning with your methylphenidates, there's going to be none left. You will have a small amount of your dexamphetamine still left in system the next morning, but it'll be a very small amount, and within another 24 hours it's gone. So unless you're on very high doses. If you're on 70 milligrams of Vyvanse and some Dexies and you want to change, you might pause for a day.
When we renew the script, what do we review? Like we check the side effects. Is there any like an ECG or anything that we need to do?
Generally speaking, if you've got no cardiac side effects, other than checking blood pressure every visit, so it's every visit's a height, a weight and a blood pressure for every kid. And how do you know the medication's working? The answer is it's based on history from the child, from the parents and from the school as appropriate. Place of work if they're in TAFE, things like that. I know I've run out of time, haven't I? One last question.
Sorry, very difficult one.
Far away.
What's your view on GP training that needs to happen before we start diagnosing?
I was kind of secretly hoping no one would ask me that question, but at the same time hoping someone would ask me that question.
I just want to know your opinion, because there's nothing obviously hard, set in stone at the moment.
What I would say for the current thing is that the current model of ADHD diagnosis and management is not fit for purpose. It was 20 years ago, it's not anymore. So something needs to change. There is a model coming. I personally don't think it's fit for purpose either. I think there needs to be something in between. And hopefully we'll see something. Because I would like to say I think all GPs should be, who are those who are interested, I'd like to see you guys more engaged with the care of these children, because I don't do a very good job with the GP stuff. I'm very focused on, next kid, see them, sort them, get their ADHD under control, off you go, next kid. So I can't spend the time to address other issues that are often actually way better managed by GPs. But I think that the divide needs to be bridged a little bit, but it's not a jump across. We need something in between. So I'd like to encourage GPs to do it, but I'd also like to see a program where you all get lots of training by appropriately skilled and experienced specialists providing that training in such a way that you then work with those specialists rather than in isolation from them. It's a bit of a vague answer, but there you go. That's it. I've been booted off, sorry. I didn't hear any music play though.
You did well with time. That's good. Thank you. It's a big topic to cover.
Yeah. Thanks everybody.
Thank you very much. That's a little thank you. Thank you very much.